So the point of today is to just kind of do an update, since maybe it's been a while since we've all looked at some of this stuff, and specifically we're going to look at these 4 different therapies, which were and are commonly, I guess, used, and just look at where the evidence comes from and how good that is. But first is remdesivir, and so this is back in May, and I'm going to try to fly through this because I think maybe in some form you've seen it, but just to highlight some things. But it's an NIH-sponsored program, Act 1, and it had 1,000 patients in 60 sites, and they looked at remdesivir versus placebo, and they looked at only they had all different tiers of patients. So, but you at least had to have one of these: infiltrates, a low sat, or requiring oxygen or some kind of respiratory support. They didn't have that much exclusion criteria that mattered to us. High ALT, AST, because remdesivir has side effects that are liver, and then some renal dysfunction. And the outcome was time to recovery. So interestingly, of all the groups, I mean, they had some ambulatory patients, but 88, almost 90% of them ended up meeting the severe criteria. And that basically means that they are desatting, because mild to moderate was a sat is greater than 94, and the respiratory is low. This is a U.S. based, so it's a lot of comorbidities that would be applicable to our patients. And you can see the distribution here in this table of how many patients of each category they had. So you can see requiring supplementation, oxygen was the biggest group, about 40%. And then some kind of invasive mechanical ventilation was the second biggest at like 20+%. So the overall results were this, and this is kind of what made the press mostly, is that 11 days in remdesivir group versus 15 days for placebo for recovery. And this was significant. The relative risk was, or the relative rate, I should say, is 1.3. Confidence interval does not pass 1. They looked at the subgroups, and you can see that really the most benefit was within the people on oxygen, so that's the upper right corner, but not on high flow or above, so no mechanical ventilation. If you looked at the people, and this is based on at the time they were enrolled, so some people could have started in one group and moved to another, but they would have stayed with their original group, so it's time from enrollment. So if you're, this is supposed to be on high flow here, and then those people on mechanical ventilation. You can see all the different Kaplan-Meier's cross each other except for the group that's on oxygen but below high flow. So that really seems to be where the benefit is in the subgroups. And again, looking at the subgroups, here's that overall group of 11 versus 15 days. But in the group that had a benefit, it's only 9 versus 7 days. You can see all the other groups. Again, these are subgroups, so you can read into them as much as you want. But when you're trying to see what's driving most of the benefit of the 11, 15 days, if the group that was the most significant was this group highlighted here, it's only 9 to 7 days. So it's actually very modest. You can see every other subgroup crosses 1. Okay, so remdesivir shortens course in hospitalized patients on oxygen, yes, based on this overall group 11 to 15, but really most of it is happening in the largest group, which is the one on oxygen, not on ventilation or high flow. And then the only benefit you're really getting there is 9 to 7 days. Okay, so what does NIH treatment guidelines say? They recommend that you use remdesivir, and you only really should prioritize this in patients that are on oxygen but not high flow. And then they say at the bottom here, there's 2, in the trial they actually used 10 days, but there's subsequently been a kind of non-inferiority trial that looked at 5 versus 10 days. So 5 days is all that's recommended, and they cannot make a recommendation for or against those that are, at the time you see them and you're deciding on remdesivir, if they're on high flow, non-invasive, or invasive. Okay, so remdesivir for oxygen, but not high flow and above. So tocilizumab was something that we used a lot, and actually this is a press release that came out, so we actually don't have anything published. But essentially what happened, they released this press release to say they're no longer, the pharmaceutical company is not really looking down this avenue, and they're looking for it to maybe be helpful in other avenues of COVID. or specific groups, but basically in 450 patients, the trial failed to meet the outcome, which was an improved clinical status. So you can see here, odds ratio crosses 1. They did have this time to hospital discharge benefit, 20 days versus 28 days, but they, in the press release, say that they could not consider this significant since the primary outcome was not met. So tocilizumab per NIH, which is, if you don't know, is an anti-IL-6, is recommended against. In the whole subgroup of immune modulators, most of them are recommended against. There's this other group that we haven't, at least that I'm aware of, used here at Georgetown, of BTK inhibitors and JAK inhibitors. And this is interesting. This is also a press release, which is what happens in COVID. Evidence comes out press release. But this is just from September 14th, so very recently. And this is Act 2. So Act 1 was remdesivir. Act 2 is this. And this baricitinib, which is a rheumatoid arthritis drug, that's a JAK kinase inhibitor. They put this press release out saying they met their primary outcome, and the paper is to follow. We don't really have much information except for that it's 4 milligram dosing, which is, I guess, the standard rheumatoid dose. It's over 1,000 patients. But this primary outcome is how much recovery time they got. So did it lead to improved recovery? And it led to about a day of improved recovery. So that's not really much, nothing to really, I think, change their management at this point. But what I want to highlight is that this study was designed of now considering remdesivir as standard of care, which may be a little bit of controversial, but I think given what other evidence we're going to review, it's the best that we have. So it actually looked at adding baricitinib to remdesivir versus remdesivir alone. So I think that's kind of considered like the new standard for trials, is that you have to compare yourself to what's the standard. And so if anything, I mean, it actually added a benefit to remdesivir. So we'll see when this actually comes out if it amounts to anything that we're going to use in practice. But you'll see that also moving forward, the other things we're going to look at, you know, remdesivir either was not really available at the time or was not proven, or for later stuff it was used and it was hard to tell who it was kind of used throughout. So I'll highlight those a little bit more. People have highlighted, like, why should this work? Well, if you're interested, it's, like I said, a JAK kinase inhibitor. And one thing it does, it supposedly prevents opsonization or entry of the virus by this mechanism. It also has a hyperinflammatory, so if you block it, it would not lead to JAK-STAT signaling, which has all these cytokines, which, you know, a lot of the hyperinflammatory sequelae of COVID are thought to be through this, but we know that tocilizumab didn't work by working on something similar to this. People have brought up that, you know, one of the things that happens when you give this to a rheumatoid arthritis patient is it reactivates their HSV, or other, like HSV is the primary one, I think CMV is the other one. And it's because you're blocking the innate immune system. So this is the way it's supposedly helping in COVID, but there's this potential side effect over here. So for right now, this is still not recommended per the NIH treatment guidelines. So moving on is convalescent plasma. I'll spend a little bit more time on this because I think this is kind of interesting. So this is the first trial that came out. It came out back in August. It's from Wuhan itself, and it was open label. They looked at the titer of the antibodies in the plasma that they were giving, which is an important point because we'll see later that that wasn't always known. They gave a dose of 200 mils, which ends up being now the standard. But what was really interesting, this was started towards the end of kind of the peak outbreak in Wuhan. And I think by the time they kind of got mobilized, they already didn't have as many patients as they thought they would. So the median time to randomization was 28 days. So these patients had already been sick for 28 days. So I think for most of us, we're going to think that that course to do an intervention at that point might be really late. And on top of that, for 200 patients that they planned to enroll, the outbreak got so controlled that they actually just didn't have any more patients. So they had to stop halfway through. So they only got to halfway through, and they were getting patients that were 28 days or on median through their course. And then you can see also that the groups got all kinds of other treatments. So there's a lot of confounders, like antivirals were given, and it was roughly even between groups, but just that's an aside. And in the end, they said no difference, but they did have this severe group that they thought was a subgroup that they said, well, this looks like a potential signal, but again, this wasn't our primary output. But maybe severe disease could show something. Here's that data again, the actual numbers. So time to clinical improvement, 19 versus 13 days for that group, which is pretty good if it holds up. But everything else, and time to discharge was similar, but everything else was kind of no difference. So their conclusions that convalescent plasma did not work, but our interpretation should be limited because they had to stop the trial early. There was another ongoing trial in the Netherlands, and it also was stopped, and we actually don't have really much of any data from it. Something similar, I think they had some protocol problems, so that one was stopped. And so we really didn't have anything. But in the meantime, in the United States, and the theory behind convalescent plasma, I think it makes sense, right? Give somebody that's gotten over it antibodies so that the next person can get better off of it. But there's, some caveats there, obviously. So what happened is we had kind of a compassionate use in the United States. And so what happened is we started giving it, even though we didn't necessarily know what we were doing. And during, those of you that were here during the peak, and we were having lots of COVID talks, I think again and again a thing came up is like, you do something, you hope at the end you have something to show for it, to show like to your patient, did this help? And so we're going to review this, which came out in August. And interestingly, it's preprint only, so it's still under review. And it's still actually, as of today, in under review. Usually that means there's been a lot of revisions. It's going back and forth between the authors and the reviewers. But most of the other COVID papers that came out that were big like this, that came out and were under review, ended up coming out much quicker. So some people point to that as being like a red flag. But anyway, so this is all across the United States, 2,800 facilities, 35,000 total transfusions were given. And they were looking for specifically this, quote, severe COVID, life-threatening COVID. They gave, you had to have gotten at least one unit, but the thing is, and you didn't know the titer, but the thing is the additional units were at the prescriber's discretion. So some people could have gotten 5 units. I don't think that ever happens, but could have gotten 2 or 3. But you would give one and you wouldn't necessarily give another one until maybe a couple days later. And the main way they evaluated the groups was about when they got it during their course. This table, I know you can't see it, it's purposefully noisy. I put it in here. If you look at this column to the right, there's not a single thing that's not significant. And what they're showing you is they actually broke up the transfusions given over this period into 3 periods, because they said the way we treated COVID in April was different than May than June, which I think was true for those of us that were through it. I'll come back to this table in detail. But for example, what are the things that were different? Well, remdesivir became available, right? So in April, no one was getting, or barely anyone was getting remdesivir unless they were part of a trial, and then it starts going up through the course. At the same time, the time to transfusion changed. So at the beginning of at least in the United States, of the use of plasma, we were waiting longer to give it to patients. Towards the end, you can see that we were giving it a little bit earlier. So it is true that these groups are different over time because we were treating COVID differently. You can see, like, for example, chloroquine numbers kind of change and drop off dramatically. So things were different from each period. But that introduces a lot of confounding, but we'll kind of dig into that a little bit more. So here's some of their results. Again, they didn't know the antibody titer when it was given. The prescriber did not know it. This was something that they had to test after the fact. And they ended up breaking, once they knew the transfusions, into low, medium, or high titer. And there is a difference. If you give high titer, it seemed to have a benefit. So this is 7-day mortality. This is 30-day mortality. The benefit is a little bit less dramatic, and some of these are not significant. But I think what I really want to highlight here is that there's kind of a difference over time. So just like things were changing from April, May, and June in terms of what we were doing, the severity changed. You can see at the beginning, people were considered severe, life-threatening 80% versus it went down over time. And the mechanical ventilation use at the beginning was very high, like 50%, and then it went down over time. So what was happening here is there was this, and mechanical ventilation was one of the criteria to define you as severe. The issue is at the time there was this kind of dogma, I guess, that you should do early mechanical ventilation. So it skewed this group to be sicker. And actually we found out later that maybe, you know, it's hard to say cause or effect, but if you ventilate a patient, they do worse, right? That kind of makes sense. But in this case, we were doing it preemptively and we probably were causing harm. And then if you remember, I mentioned that in this first group, we also were giving the plasma later. So they're sicker on paper, probably we're doing things that aren't great, like mechanical ventilation earlier, and we're giving plasma later. And so their big outcome, but their big outcome was that if it's given to you less than 3 days, you do better than you do if you get it after 4 days. And so there's no control arm. All they're doing is comparing plasma to plasma. If you give it earlier and you give high titer, maybe that's better, but that's comparing it to kind of different populations because we treated them differently over the period of time. And so I'm kind of confused by this trial, and hopefully you're confused by me just talking and rambling. But I think if you kind of take a step back and think, when, to me, this is kind of shocking. Like, when have we ever given 35,000 treatments of something and really had so little to show for it, right? You know, I mean, it's almost like unethical, I think. You know, if you think, like, if you're going to go to your patient and you're going to consent them to say, because we have to consent for plasma, what are you going to tell them? How well does it work? You know, are there downsides? You know, it's the same as any plasma, I guess. But, you know, I don't know. I mean, I think it's a little bit crazy to think we have so little to show for 35,000 treatments. And that's because we didn't have really a control arm and we can only compare it to itself. Interestingly, since then, this is, again, it's a preprint that hasn't been peer-reviewed, but this is the way COVID works. This is September 10th, right? So this is the first randomized trial that actually has gone to completion. So remember, I told you the first one in China had to cut off early, and so the one in Netherlands, they couldn't even report. This one went to completion, and it's 464 adults with severe but not the most severe disease, so PA to FiO2 ratio of 200 to 300, but they excluded the less than 200, anybody in shock. And this time they give 2 transfusions, which I think we started to learn more is probably better since sometimes the titer is unknown. And they also prefer to give separate donors because it's interesting, some people recover and they have very little antibodies, some people recover and they have a ton. Again, the titer is unknown in transfusion. Here, remdesivir, this was mostly in May through July. And it should have been standard of care. I guess maybe wasn't available in India. But the steroids were, and quite a bit of patients got steroids. It's roughly equal. So here's the results, and this is a lot of stuff. But the 2 columns that are overall groups are standard of care in this column and all. And there's no difference at mortality, progression to severe disease, and the composite of the 2 together. So there's completely no difference. And then they looked at subsets again with basically roughly medium antibodies, high titer antibodies, and some people had, you know, actually 64, so about a third of the people that got plasma had undetectable antibodies. Right, so that's something to contend with plasma. There's, you know, you don't know what you're getting into. Some people could literally give plasma and had no antibodies in it. And again, there's no difference in any of these subgroups. So even in this high titer group, there was no difference. Of course, this is pretty small, and you can see these are wide confidence intervals, but there's not even a signal. So right now, their conclusion is that plasma is not associated with any reduction in mortality or progression to severe disease. But you know, maybe if you know the titers in advance and then transfuse them, you could target a trial that way. NIH says there are insufficient data to recommend either for or against the use of plasma. So I think that, you know, first off, you may have seen stuff in the news about how this is getting pushed. quote by the FDA. And just remember that the FDA is like a huge organization. So just because one person's doing it doesn't mean everybody there is doing it. And on top of that, this is as good as the evidence gets. And doesn't mean we shouldn't necessarily use it, but probably it means we should keep studying instead of just using it without getting information. Because if we're another 6 months from now, we still have the same quality data, we'll be kind of kicking ourselves, I think. So plasma, basically not enough data, and this actually doesn't include this information from September. So it may actually come back around and say there's no way to make a recommendation for it. Data, and so this is from the recovery trial, which came out in July. It is randomized, it's open label again. It had over 6,000 patients, and they did kind of 2 to 1, where two were in usual care because they had other arms of the study going on, and 1 was in dexamethasone, and the regimen was 6 milligrams daily for up to 10 days. So here's what their results look like, and I'm going to blow through this because there's actually more on steroids since this has come out. But basically things look good. So overall, the relative risk was 0.83. So dexamethasone had a benefit in overall, and most of this was driven by those on ventilators. So you can see how it's a much bigger group. Looking at other subgroups, the people on oxygen but not ventilation still had some benefit. You can see how close this confidence interval comes to 1. And then those people receiving no oxygen, they say, quote, had a tendency to harm, but this crosses over 1, so it's basically no difference. This is the same data looked in a different way, but you can see the overall effect is this 0.83, but it's mostly driven by the mechanical ventilation and somewhat driven by the people on oxygen but not mechanical ventilation, right? So that's the larger group. And just pay attention to these numbers on the oxygen-only group, 1279 to 2604. Okay. One of the things that it's in the supplementary data, but it's since been used to kind of help you decide who gets steroids, is looking at some other, but these are pre-specified subgroups. And so doesn't seem to be, there's maybe a sex difference, an age difference, but one of the big ones here is days from symptom onset. So the people that had symptoms from over 7 days had a benefit, and if it's been less than 7 days, they had no benefit. Okay, so keep that in mind. Steroids for over 7 days had a benefit. Oops. So here's a meta-analysis that's come out since then. It just was published at the beginning of this month. And you can see how many trials now that there have been with steroids. Recovery is here in the middle. It is the largest one of all of them. And I'll tell you that it's kind of the only one that really had a sizable group of non-ICU patients. Most of them were kind of targeted towards ICU population. So what did they look at? So here they in meta-analysis, they pull the results together. So for example, dexamethasone, you can see the recovery trial is highlighted here. It has its largest, so it has most of the weight, and but when they pull everything together, it still has a benefit. Okay, so it's actually pretty far from 1.66. What's interesting is that which groups are, again, getting the most of the benefit. So it's still the mechanical ventilation group, right? And this is the same 1279 and 2604, because the people that are not on ventilators, on just oxygen only, they redid the calculation using their kind of own statistical assumptions, because whenever you do meta-analysis, you have to make some assumptions. And they actually get a different confidence interval. So this time they smack hit 1. So this exact same numbers, 1279, 2604. Recovery said it was beneficial in people on oxygen, and this one is, but it crosses 1. Same data, just different way of analyzing it, right? And then the same, again, this is pretty much all driven by recovery. So from one study, still it's a 7-day benefit, where less than 7 days maybe has it, but you can see it crosses 1. So what do the guidelines say about this? So you should use dexamethasone for up to 10 days in patients who are mechanically ventilated. This is level A evidence. But in hospitalized patients who require oxygen but are not ventilated, you can use it, but it's level B evidence. If you don't have dexamethasone, you can use prednisone, methylpred, or hydrochloride. Definitely recommend against dexamethasone for those who don't require oxygen. So went through that really quickly on purpose, just not to bore you, but here's the major takeaway. So remdesivir is maybe standard of care, but it only has modest effects. Overall, it was 11 versus 15 days, but in the group that it showed an effect, it was 7 versus 9 days to recovery. And it's overall recommended for those on oxygen, but not on anything higher than high flow nasal cannula. Tocilizumab and any other immune modulator right now is not recommended. Convalescent plasma doesn't have very good evidence, and so there's insufficient evidence for them to make a recommendation, but the largest completed randomized trial actually says there's no benefit. Steroids work for those that are on invasive mechanical ventilation. One subgroup I didn't show you was if you're on vasoactive medication. So if you're sick enough to be in the ICU on ventilation, but have to get on pressors, it doesn't seem like you benefit. The borderline benefit if you're on any oxygen below mechanical ventilation. So again, that was the original recovery, it was like confidence interval up to 0.93, I think. And then in the subsequent reanalysis, it was up to 1. There's definitely no benefit if you're not on oxygen, and the most of the benefit seems to be if it's over 7 days of symptoms.